Hello, and thank you for joining today's webinar, The Impact of the COVID-19 Pandemic on Immunization Coverage, Data from a Network of Practices in Ontario. This webinar is the second part of our first webinar from July 2021 on the impact of COVID-19 pandemic on immunization services, results from a survey of physicians in Ontario. My name is Antonella Pucci, and I'm a project officer at the Canadian Public Health Association, and I will be the moderator for today's webinar. Once again, it's our pleasure to be collaborating with Immunize Canada again to host another four-part webinar series on the topic of immunizations during the SARS-CoV-2 pandemic. To learn more about upcoming webinars, please visit our website at canvax.ca/joint Immunize Canada and Canvax webinar series, as indicated in the link you see on the screen. Before we begin, we want to acknowledge that the offices of Immunize Canada and Canvax, which are part of the Canadian Public Health Association, are situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. Immunize Canada, Canvax, and CPHA are committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. For a bit of housekeeping, it should be noted that all attendees are muted. For this webinar, the Q&A feature located on the toolbar will be used to ask questions. If you have any questions, please type them in the Q&A box, and you can do that at any point during the webinar. Only you, myself, and the presenter can see the questions in the My Questions section. And when asking a question to the presenter, the question is first read out loud, answered live by the presenter, and then posted in the All Questions section. If you have any questions regarding technical difficulties, please contact canvax@cpha.ca, and we'll reply to you as soon as we can. And if multiple people are experiencing the same problem, then we'll address it live in a broadcast message. Just as for some quick notes, the webinar is being recorded and will eventually be made available on Immunize Canada's YouTube channel and on canvax.ca. Slides will also eventually be shared as well, but at the moment, the recording will be temporarily available upon request. Look for more details in the post-webinar email and as well as on the Canvax website. And secondly, we invite you to take a short 5-minute post-evaluation survey at the end to provide your feedback on the delivery of this webinar. But with that being said, let's begin. We have the pleasure of welcoming back Dr. Pierre-Philippe Piché-Runeau to present today's webinar. Dr. Piché-Runeau has completed his pediatric training at the CHU Saint-Justin in Montreal and is now finishing his second year of subspecialty training in pediatric infectious diseases at the Hospital for Sick Children. Throughout his fellowship, he has been involved in Sick Kids COVID-19 Pandemic Response Plan and has also been studying the impact of the pandemic on routine childhood immunization in Ontario and strategies to mitigate any decrease in vaccine coverage. So I'd like to turn it over to you, Pierre-Philippe.
Thank you very much, Antonella. So I'll just share my screen here to show these few slides. There you go. So first of all, I just wanted to thank everyone for joining this webinar, for your time, and to take some of the time in your precious schedules to reflect on the Ontario experience around misimmunization secondary to the pandemic, which is very important topic that is fortunately getting some recognition. And I would want to take the Canvax and the Immunize Canada team in fostering interest and the focus around this topic specifically. As Antonella mentioned, I'm an pediatric infectious diseases fellow at the Hospital for Sick Children, a research and clinical fellow. So this webinar is actually the second webinar I'm giving to the series. The first one that had focused mostly on a survey study of physicians that we had done throughout Ontario, including family physicians and pediatricians. Today we're going to focus on another study that we have conducted with a partnership with the Utopian Network, which is a network of practices in Ontario. So here are my disclosures. Also clearly, some of this work has been funded by a Pfizer Global Medical Grant, but this is completely investigator-led, and the funder had nothing to do with the design of the study. So first of all, before we go in the study in itself, we're just going to go through a few definitions and go through how we can assess the vaccine uptake and the vaccine coverage in Canada and Ontario, and kind of dissect how this is done and what are the methods that could be used to identify a potential problem with the immunization coverage secondary to the COVID-19 pandemic. So it doesn't come through as a surprise that COVID-19 has affected a lot of health services, including for children, which includes obviously immunization services. And this phenomenon has been documented worldwide, including in modeling studies from the Institute of Health Metrics and Evaluation, which has modeled what could be the impact in various continents. And we can see that there has been a substantial decrease that has been seen in the initial phase of the pandemic, with some increase in the subsequent phases. And this has been the case in some high-income country, as well as Europe. So this phenomenon has been documented. You can see here the countries from which this evaluation has been conducted, but you can see here that data is limited in Canada. And this evaluation is hard to do in Canada because of multiple reasons, which we will go through. So there are some challenges in gathering data on immunization coverage in Canada specifically. And the reasons for that are multiple. The first of these reasons is, as you probably know, that there is a different vaccine schedule and different delivery models in each provinces, because healthcare is something that is delivered by the province. So even though the National Advisory Committee on Immunization, so NACI, will emit general recommendation on immunization schedule, the provinces will decide if they follow NACI guidance or not. So each province will adopt their own schedule, and each province will decide how they deliver vaccines and by whom these vaccines will be delivered. So this is a study that was published by Sarah Wilson and a team of researchers here in Ontario, looking at the different delivery models in each province. So you can see that there are discrepancies. This is from a very high level analysis. So you can see that most of the previous province, so Alberta and Saskatchewan, has a public health delivery system. So public health is purely responsible for the delivery of vaccines, whereas other provinces such as Quebec and Ontario have a mixed delivery model. That is, that primary care and public health are both responsible to administer vaccines to children. So this is one of the reasons why it can be challenging to obtain adequate data on immunization coverage, because public health uses a different system than the system that is used in primary care. So this is something to be mindful of. And not only the delivery system and the immunization schedules are different, but there are significant differences between immunization information systems in each province. And there is no centralized electronic national repository for vaccination. So each province does something a bit differently. And most significantly, most of the information on immunization coverage is actually gathered in one of these kind of immunization record. That is a paper record. This is the one that is being used in Ontario, so this yellow card. So for parents, there is not one central repository for all of their vaccines, but there are multiple repositories, and we'll go through some of these differences. You can see here, this table is a bit full of information, but it's also from the same article by Sarah Wilson, looking at what are the immunization information system in each province. And you can see that there are significant differences. You can see here that Ontario uses Panorama as the immunization system, but Panorama is used for public health and school-based immunization programs, and not for routine childhood immunization. So not all vaccines will be documented in that. So all of these systems have different information in them, and will use different models to gather different kind of information. And not all information on immunization will be held in such registries. Another important variable to take note of is that each province has a different assessment and has a different definition for vaccine coverage. So we'll go through very quickly at a very high level some of these definitions with respect to vaccine coverage and vaccine uptake. So first of all, we hear a lot about vaccine acceptance, but vaccine acceptance is something that is completely different than vaccine uptake and vaccine coverage. So when we hear about vaccine acceptance, we're thinking about the an individual or a group decision to accept or refuse a vaccine when presented with an opportunity to receive a vaccine. So if somebody is vaccine acceptant, that will not necessarily translate in that person receiving the vaccine, which is different than vaccine administration. When we talk about vaccine administration or dose of vaccines that are being delivered or administered, it's just an absolute number of vaccines that are being administered to children or patients in general. And the difference between vaccine administration and vaccine uptake and vaccine coverage is that vaccine administration does not necessarily include a denominator. So we will not necessarily have an idea of what proportion of the population will be given a vaccine. So this is an important nuance to consider, especially when evaluating the impact of the COVID-19 pandemic on immunization, because multiple studies have documented an impact on vaccine administration or vaccine delivery without assessing what is the impact of vaccine uptake or vaccine coverage. So for vaccine uptake, this concept relates more to a general idea about a group or patients receiving a vaccine. And it includes the idea that it is a proportion. So a number of people who would be eligible for vaccination would receive a vaccine, which is sometimes used interchangeably with vaccine coverage, which is the percentage of the proportion of people within a population who have received one or more vaccines in relationship to the overall population, which is the denominator that is looked at. And within vaccine coverage, it's important to define the specific term, which is up-to-date coverage versus on-time coverage. So when we refer to up-to-date coverage, this is the assessment of coverage by a specific age, in a specific age cohort in relationship to how many doses of the vaccine they have received by a particular milestone, which is the denominator. And this will be different, obviously, by province, because each province will have a different schedule. So an example of that is that we would assess all children who are aged 2 and look if they receive 4 doses or more of the vaccine, of a pertussis containing vaccine. So this is different than the on-time coverage, which is a proportion of children in a particular age cohort who have received all valid doses by a specific milestone age for multiple vaccine series as per the provincial schedule. So in general, the on-time coverage is more stringent in the criteria for assessment. So if 1 dose of vaccine is late, the child will not be considered on time. And usually to measure the on-time coverage, there is a leeway period that is used, and most typically it is a 1-month period for that. And an example of that is that all doses for all recommended vaccine are administered within 1 month of recommended interval. So these are important concepts to understand because each province have different public health standards and different criteria in assessing what are their immunization coverage at the population level. So this has also been documented in a study by Sarah Wilson and her team. And you can see here what are different markers to assess immunization coverage. So you can see here that in Ontario, what is measured is that a specific method at looking at the coverage of 7 years old, because at 7 years old, when kids are going to school, all vaccines dosage should be documented by parents in the central repository. So you can see that not only there is a different definition for on-time versus up-to-date coverage, but there is also different age milestones at which this is being assessed. So this is the reason why when you look across provinces, there are different significant differences in the percentage of the population that is considered vaccinated appropriately. So we will go a little bit more deeper in the Ontario experience. So you can see here what is the publicly available, publicly funded schedule for Ontario. So you can see here the doses that are given at less than 2 years of age. This includes 4 doses of the pertussis containing vaccine, including at 2, 4, 6, and 18 months of age, 3 doses of the pneumococcal conjugate 13 vaccine, 2 or 3 doses of the rotavirus vaccine, MMR vaccine, meningococcal vaccine, meningococcal group C, as well as varicella vaccine. And this is an interesting difference to note with some other provinces, that the VZV vaccine is given at 15 months old, and not jointly with the MMR vaccine, which is different than in other provinces. So these vaccines are all given, or mostly given, in primary care settings, that is by a primary care physician, either a family physician or a pediatrician, and not by public health unit or not by nurses. Or if it is given by nurses, it is within primary care practices. This is different than the school-based immunization program, including vaccine against hepatitis B, as well as the quadrivalent meningococcal vaccine and the HPV vaccine, which is given in schools. And this is given by, this is the responsibility of public health and public health units. But we'll talk a little bit more later about school-based programs. So for our study, what we have done is that we have partnered with the Utopian Network, which is the University of Toronto Practice-Based Research Network, and it is a network of primary care electronic medical records data. So this englobes many practices throughout the Greater Toronto area and beyond. So using data from their EMR system, we have conducted an observational retrospective open cohort study from January 2019 to December 2020 to see exactly what was happening with patients, with children aged less than 2 years old in their vaccine coverage throughout the pandemic. So what we have done is that, just to kind of explain the high level idea behind Utopian. So the data from that network includes de-identified patient records from EMR from all contributing family physicians practices who are associated with the University of Toronto, which represent about 70% of the practices throughout the Greater Toronto area. So this includes patient-level socio-demographic data, including the date of birth, the sex, and the postal code, as well as immunization records from the EMR itself, which include which vaccine is given and at what date it is given. To note, in the EMR system, there is no patient-level information on patients' income or material deprivation or ethnicity, but this data it can be gathered through the linkage with a postal code. So this data was gathered for our study specifically, including the neighborhood income, the material deprivation index from the neighborhood, as well as ethnic concentration quintile based on the patient postal code. So for this study, this was an open cohort of all children who were aged 0 to 2 years old during the study period, and who had a valid sex and a valid date of birth in their EMR, just to make sure that there was no issue with data entry. Patients needed to have at least two visits recorded in their EMR, just to ensure continuity of care and to ensure that we would capture data that patients would not go in another practice to get their vaccines and hence would bias their results. So this was another marker of validity that was used. And just of note, during the study period, most people will be familiar with the situation of Ontario, but at that time, Ontario was the second highest, the province with the second highest number of COVID-19 cases, just below Quebec, with 30% of the province's cases reported in the Greater Toronto area. So most of the cases being unsurprisingly concentrated around this area. So for our outcomes, what we have done is, in order to be able to have the highest possible comparison with other provinces and to look at the most precise outcomes as possible, is that we have assessed both up-to-date coverage and on-time coverage using validated and universal definitions for that. So for up-to-date coverage, what we have looked at is the proportion of children who have received all recommended doses required by a specific age or point in time. And we have disaggregated these results for all antigens, that is for all vaccines, and by specific antigen. So this was our main outcome of interest. And secondly, we have looked at on-time immunization coverage. That is the proportion of children in a particular age cohort who have received all recommended doses for that specific age milestone. So this is purely based on age and not based on the antigen. And it includes a 3-day leeway period after the recommended date for vaccine administration. And the age milestones that we've looked at are 2, 4, 6, 12, 15 months old for the DZV vaccine specifically, and 18 months old. I mean, I showed the detailed publicly funded immunization schedule in Ontario, but just as a refresher and to show what specific ages were age of interest. You can see here the pertussis-containing vaccines at 2, 4, 6, 18 months. The conjugate pneumococcal vaccine at 2, 4, 12 months old. The rotavirus vaccine is of significance because the Rotarix vaccine is a 2-dose schedule, whereas the Rotatec vaccine is a 3 doses schedule at 2, 4, and 6 months old. So we have also considered that in our calculation of the up-to-date and the on-time vaccination. We looked at obviously MenC, MMR, and varicella vaccine at 15 months of age. So for our data analysis, we did weekly immunization coverage rates between January 6, 2019, to have at least 1 year of look back before the pandemic, to December 20, 2020, to capture at least not only the first phase of the pandemic, at which time there were a lot of reports around the decrease of immunization coverage, but also to capture the second wave of the pandemic, as well as the later phases of the pandemic when we were reopening, to see if there was if we had found an initial drop in the immunization coverage rates, if this rate would be improved further down in the pandemic. We have conducted linear regression models to compare the average coverage rates over 3 periods of time. So the first period was the baseline pre-pandemic period, so from January 6, 2019 to March 14, 2020, which was the pandemic declaration of emergency here in Ontario. Then our second period was the early pandemic phase during the first lockdown in Ontario, which was from March 15 to August 1st. And then our third period was later in the pandemic during the initial reopening phases, after the first wave and the beginning of the second wave from August. So this whole period was August 2nd to December 26th. So we did fitting adjusted regression models to examine if there was differences in on-time immunization coverage over the 3 time periods, and to see if there was any association with patients' social demographic characteristics, and if public health efforts would need to be concentrated on some specific populations. So here are the characteristics from our cohort in general. So you can see here that in total, we have included a little bit more than 12,000 children, the majority of whom were in an urban region, which is unsurprising, so mostly throughout the Greater Toronto area. So 87.2% of children were in the urban region, and a third of our patients were in a neighborhood that is most ethnically diverse, in the most ethnically diverse quintile, which is unsurprising given the population in the Greater Toronto area. You can see here what was the birth year of all patients. So some patients were born in 2017 and were included in the cohort because they were getting 2 years old at the time of the beginning of the study. The distribution of patients was relatively similar for all birth years. About 50% were male, about 50% were female. I've mentioned about the patient's location, and you can see here the distribution across neighborhood income quintiles, which is relatively similar across all of these quintiles. Similarly for neighborhood material deprivation quintiles, so relatively similar and equal distribution in all of these quintiles. And lastly, around the ethnic concentration quintiles. So here is what we found with respect to the overall up-to-date coverage. So you can see here that at baseline, about 71% of our patients were considered to be up-to-date in the pre-pandemic period. And we saw that there was indeed a significant decrease in the average up-to-date coverage rate from the initial period, the pre-pandemic phase, to the initial pandemic phase, that is from March 2020 until August 2020. And you can see here that there was a 5.7% decrease in the up-to-date coverage, with a p-value that was significant and less than 0.0001. And then what we saw, which was interesting to note, is that similarly to what has been described elsewhere, There was a bit of an increase in the third period in the reopening phase, but this decrease did not go back to pre-pandemic levels. So you can see here that there was more than 1% increase from the second period to the third period with the reopening, but there was still a decrease of 4.1% in the third period compared to the pre-pandemic level up-to-date coverage in our patients' population. If we look at the up-to-date coverage by vaccine, we can see what are the main drivers for this relatively low baseline up-to-date coverage. And we need to consider that in our study, we have included patients who are in all age ranges. So that includes from 0 to 2 years old for the calculation of up-to-date coverage. So you can see here that for the pertussis-containing vaccine, the baseline coverage is around 85%, and there was a significant decrease, and we'll go through these results. That is mostly driven by the 18 months group, and we'll go through these specific findings by age as well. You can see milder decrease for the pneumococcal vaccine, mild decrease for the rotavirus vaccine, mild decrease for the meningococcal vaccine and the MMR, and the most significant decrease being for the varicella vaccine. And you can see that the pre-pandemic baseline coverage was lower than other vaccine, given that it is only given at 15 months of age, and there was a more significant decrease in that during the pandemic period. And we'll go through the reasons for why that may be. You can see here the specific numbers for each antigen. You can see that the decrease in immunization coverage and up-to-date coverage for each of these vaccines was significant. That is statistically significant and not necessarily clinically significant in that, for example, for the pneumococcal vaccine, the decrease was relatively mild and was 0.8% in the initial pandemic period and 1.1% in the third period. More important drop was seen with the overall coverage for the pertussis-containing vaccine, with 3.4% in the initial phase and 2.5% in the reopening phase. And this is once again mostly driven by the booster doses that is given at 18 months. You can see here that there's been a decrease in the rotavirus vaccine as well, meningococcal vaccine, meningococcal serogroup C vaccine, the MMR vaccine. Interesting to note that there's been a 1.7% decrease in the first pandemic period, and 1.9% decrease in the reopening phase. And once again, most significantly, a decrease in the varicella vaccine, with a 6.3% drop in the initial pandemic phase and 5.7% drop in the reopening phase. So very importantly, to take a look at age-specific milestones. And for that, we're talking not about the overall up-to-date coverage, but the on-time coverage by age milestone. So this is the reason why these results may be somewhat different, but it can provide some explanations as to which age group is driving the most significant differences that we're seeing by antigen. So you can see here that in younger infants, the drop in coverage was actually not that significant, if at all, compared to older children. Most significantly in the 18 months group, we can see that the on-time coverage declined significantly. And when we take a look at these specific results and the numbers of the percentages by which we've seen any decline, you can see here that at the 15 months milestone, first of all, the coverage is much lower with respect to on-time coverage. That is that all vaccines that are required up to 15 months of age need to be given within a 1-month leeway period. So that is a more stringent criteria to assess the coverage. We can see that there was a significant decline in the initial pandemic phase, somewhat of a catch-up in the reopening phase, but something that remains statistically different than what was seen in the pre-pandemic period. And as we move up the ages, we can see that this difference becomes less and less statistically different. So for 6-month-old and for 12 months old, the baseline coverage remains obviously lower than younger children. And there was also a statistically significant drop in on-time immunization coverage that was seen in the initial pandemic period. But fortunately, this was appropriately cut up during the reopening phase. And you can see here that there is no statistically differences between the reopening phase with respect to on-time coverage compared to pre-pandemic periods. And interestingly, we can see that across all periods, for young children aged 2 months old and for young children aged 4 months old, we can see that there is a trend towards a decrease in on-time immunization coverage, but this decrease was not statistically significant. So this is an interesting figure. It's full of information. So we'll go through it by each of the patient's characteristics. Some of these findings are of interest. So these are the disaggregated results by age milestones and by social demographic characteristics over the 3 period of time. So you can see here the results for all 2 months old, 4 months old, 6 months old, 12, 15, and 18 months old for on-time immunization coverage. And we disaggregated this analysis by sex. And you can see here that the coverage is overall similar. By location, and you can see here that the overall baseline coverage is relatively lower for patients in urban area compared to rural area, with a decline that seems to be somewhat more important in urban compared to rural area, but this decline was not statistically significant. And now when we disaggregate the analysis by neighborhood level information, that is by the information that has been gathered through the patient's postal code, we can see that overall the baseline immunization coverage is lower for neighborhood who are who have the lowest income, in the neighborhood that are the most materially deprived, and in neighborhood that are the most ethnically diverse. So we can see here that the baseline immunization coverage is lower, but when we look at the decline in immunization coverage is the same across all these groups. So this is a tiny figure, so you may not be able to appreciate the exact decline, but the decline and the curve was similar in all of these population, with the only difference that the baseline immunization coverage, unsurprisingly, is different. So with respect to some of our conclusion, so overall our results have shown similar trends to reports in other jurisdictions, that is a significant decline in immunization coverage rates, including on-time and up-to-date coverage in the initial phase of the pandemic, an increase in the immunization coverage in reopening phase, but levels that have not gone back to pre-pandemic level until December 2020. So childhood immunization coverage under 2 years old has declined significantly, especially in 15 and the 18 months age group. So some groups of children, based on the last figures that I just showed, should be prioritized for immunization catch-up strategies, not necessarily because they have experienced a steeper decline, but because their baseline immunization coverage was found to be overall lower, and hence they may be more prone to develop vaccine-preventable diseases, and they should be targeted more specifically. There are obviously some limitations to this study, and that our results may not necessarily be generalizable to settings with lower COVID-19 incidence, for example, or in other provinces with different vaccine delivery modes, or in populations where children have limited access to primary care or family physicians, or once again, in other provinces where the delivery is different through, for example, public health delivery models. So the use of EMR data is an interesting tool, and is a tool that we have validated, and there has been like a lot of work that was put in validating the immunization data from all the patients' EMR, but there can still be some misclassification bias, and there can still be some issues with the documentation of the vaccine that may not have necessarily been seen with the validation process. So this was just to mention some of the limitations from our study. So just to go through some of the possible solutions to this decline that we have seen, and to go through some of the future directions that needs to be taken with respect to research and other other initiatives around this specific topic here in Ontario and beyond. So certainly there are some solutions for decreased coverage in routine childhood immunization or specific study. This specific study did not look at possible solutions, and we have just exposed some of the possible gaps. And this is a purely epidemiological study. However, there has been a lot of work with respect to finding possible solutions, including with public health instances and including from a government perspective here in Ontario and in Canada. And this included public messaging, including in the beginning of the pandemic, and the Public Health Agency of Canada and the National Advisory Committee on Immunization had put forward messaging for all providers and all immunizers that vaccination for infant and toddlers, that is 18 months and younger, should continue to be vaccinated even during the pandemic, and their primary immunization series should be prioritized. And this messaging is probably part of the explanation why we found a more significant decline in older patients. But we need to be mindful that there are specific study population was in 2 years and children who are 2 years and younger, so who remain children that are overall younger. Very sorry about that. So in overall children who are overall younger, and did not include children who are 4 to 6 years old and children who are given vaccine in school-based settings. So what they had mentioned initially during the pandemic is that boosters given between age 4 to 6 can be deferred, but that the administration of primary series should be prioritized once again. And our study was not able to capture this specific patient population. And what was mentioned is that school-based immunization should be given when schools reopen, and there were a couple of issues around that, and we'll go through them relatively quickly in a few slides. So just to go through some of the other work that we have done through a survey study that was presented before. So these are possible solutions that we had identified initially in the initial pandemic phase, that is when there was a steeper decline in immunization. But we could see from our utopian study that the decline had not yet caught up to pre-pandemic levels. So some of these strategies may still be applicable and may still be implemented in settings that are given immunization for young children. That is assistance in providing PPE to practices and making sure that environments are safe for patients and that parents feel that it is safe to go for their routine childhood immunization. Thinking about dedicated centers or practices for vaccination. This is something that came up a lot in this survey study that we conducted, but it is extremely relevant, especially in the setting of mass immunization clinics that were led throughout the rollout of the COVID-19 vaccine. And that could be, which are settings that could be capitalized on for possible catch-up strategies in provinces. And then other strategies were mentioned, including centralized guidance, including subsidies for practices, and including to ensure that the vaccine supply is adequate, which was an issue initially in the pandemic, to have adequate supply of vaccines. And something that is quite interesting to note is a centralized immunization record. We talked about some of the pitfalls of gathering data on immunization coverage at the beginning of this webinar. So certainly having one universal repository in the province that would capture adequate data on the immunization of all children would be most useful in assessing exactly what is happening with vaccines. So another important future direction based on what we've done through this study, that is to assess the coverage in children less than 2 years old, now that we are going further in the reopening phase and that catch-up strategies are being implemented and that further research on this topic is needed, is to look at older children, that is children aged 4 to 6 years old requiring boosters, and children who receive vaccines in school-based programs. So with our studies, we have not looked at this specifically, but we certainly know based on work from other teams that school-based immunization program were significantly impacted by the pandemic. This is a study by Dr. Shannon McDonald, who presented some of her data in a previous webinar, in a previous CanVax webinar, but her team has identified and has talked to multiple provincial instances about the impact on their immunization programs. And what was found is that the school-based program were the programs that are most affected. And this is especially significant in Ontario, where schools were closed for a long period of time, and the school-based immunization programs were stunted for the full duration that schools have been closed, and they have reopened just this September. Some public health unit have done a lot of work to make sure that children remain up to date, but there is still ongoing work in catching up on some of the immunization that were missed in school-based programs throughout the pandemic. I've also collaborated with a team at the Center for Vaccine Preventable Diseases at the Dalla School of Public Health here at U of T in coming with this report on solutions to maintain immunization for school-age children during the pandemic that involved work with folks from Immunize Canada who have endorsed this document. This is just to show some of the high-level recommendations that we have made for multiple stakeholders. As you may have seen, this report was posted relatively recently in September in trying to engage all stakeholders in finding possible solutions to missed immunization with a specific focus on school-based immunization that includes recommendation for advocacy with governments, as well as strengthening strategies from a public health level and strengthening the capacity of primary care physicians and pharmacists in the province of Ontario. Obviously, this is specific to the context of Ontario, and given that all provinces have different delivery models for vaccine, this may not necessarily apply to other settings. We have also made some recommendations for schools, community leaders, and most significantly, caregivers. So this is something that I have not yet mentioned, but in another study, in our survey study, we have identified that practitioners were finding that caregiver anxiety around COVID-19 was one of the most significant barriers to their immunization services. So certainly to have public-facing messaging for caregivers that it is important to get their children vaccinated. Yes, they're teenager for COVID-19 vaccine if they are eligible between 12 to 17 years old, and probably in the near future for 5 to 11 years old, but also for the other routine childhood immunization, and that it is safe to go to their primary care provider to get their vaccines and to go in immunization settings for their children to be caught up in any missed doses of vaccination. And especially with the pitfalls of gathering data and gathering proper immunization coverage data in Ontario and in Canada, it's very important to engage caregivers, as they may be the only one of the only people who may be aware that their child have gaps in their immunization coverage. So it's really important to engage all of these stakeholders, and this is what we have explicitly said in this report. Last but not least, it will be important to conduct and to work with public health and government instances in monitoring what is the possible impact of what has been seen with respect to immunization coverage on other diseases and vaccine preventable diseases. Now that we are in the reopening phases and that things are reopening up and travel restrictions are loosening, we are seeing increase in other infections beyond COVID-19. Not necessarily vaccine preventable diseases, but most significantly RSV. So you can see here this little red line that you can see here is what has been reported for 2021 by the National Database on Respiratory Viruses. So you can see that we're seeing much higher level than what has been seen in prior years for RSV throughout the country, and most specifically in some provinces. We are not seeing this with influenza, but time will tell in the near future if we will see it, but it will be really important to have a focus on influenza vaccines as well. But you can see here that there's been an increase in other respiratory viruses, including parainfluenza as well, and enterorhinovirus that was seen quite highly last year as well. This is what has been seen in the US. So you can see here that the percentage positivity for RSV in the US is also quite high. And to look at one specific VPD in the United States, you can see here that relatively recently, so that is in the summer of this year, there's been a very high level of rotavirus that has been reported, which may tie in with what we're seeing with other viruses, but as well as a potential decline in rotavirus immunization coverage rates in the US. So it will be very important to monitor that very carefully here in Canada. So at a global level, this is something that has been documented, unfortunately, and it's a reason, and it's data that reinforces the importance of the assessment of the impact of the pandemic on immunization coverage, finding solutions to potential gaps, and working with various stakeholders to ensure that kids are maintaining their immunization coverages, especially as travel restrictions are loosening, because we can see that at a global level, there's been an increase in the reported cases of diphtheria. Mumps has been relatively stable, and there's been an increase in the cases of measles that have been reported. So this is data from the WHO. So this is there's also modeling that is included in that, but also cases that have been reported. But you can see here that for the year 2020, there's been a significant increase in the cases that have been reported. It reinforces the importance of this specific questions around immunization here in Canada that remains a topic that is of significant importance. And this has also been documented in the region of the Americas, including for diphtheria, also for mumps, and also for measles. So it will be very important to ensure that there are not outbreaks of measles, especially in communities in which immunization may have declined more during the pandemic. So in conclusion, we have noted from our study that there has been a significant impact of the COVID-19 immunization coverage here in Ontario through our data and our study from a network of practices of primary care practices in children aged less than 2 years old. So this decrease in immunization coverage could lead to an increase in vaccine preventable diseases that we hope that we will not find, especially if we're able to find solutions to this decrease in immunization coverage. But this will be important, especially with the relaxing of physical distancing measures and travel restrictions. And once again, the catch-up strategies should be implemented by multiple stakeholders, including healthcare providers, public health units, and public health organizations, as well as governments. Just to acknowledge the very important amount of work that has been put in this study by all of the Utopian network team that includes Dr. Kadrin G, Dr. Karen Tu, who is the principal investigator in that study with Dr. Kadrin G, as well as Dr. Ellen Stevenson and Jamie Sharapaji, as well as some of our other collaborators outside of the Utopian network. Dr. Morris, who is a pediatric infectious diseases physician, who I work very closely with at SickKids, Dr. Milena Forte, Dr. Jeremy Friedman, Dr. Stanley Zotkin, and finally, Dr. Michelle Science for comments on this project. So with that, I'm happy to take any questions or any comments that you may have.
Thank you so much, Pierre-Philippe, for yet another wonderful presentation, and also for sharing your results on immunization coverage in Ontario. At this point, if you have any questions, please submit them in the Q&A box. And as a reminder, you can submit your questions anonymously. We actually do have a question that just came in, and it was a question I had on my mind as well, especially as we're getting close to approving the COVID-19 vaccine for ages 5 to 11. But this person asks, has there been any efforts of administering catch-up school vaccines and offering COVID vaccines at the same time?
Yes, that's an excellent question. And so maybe I can go back to our report in that. The recommendation from the National Advisory Committee on Immunization until very recently was not to co-administer COVID-19 vaccines with other vaccines. So this recommendation was changed a few months back by the CDC in the United States, but in Canada it remained as such until very recently. So in a report, what we had mentioned for advisory bodies is that to change the recommendation and to be able to co-administer vaccines will make catch-up strategies much easier because there's a lot of interest around and there's a lot of attention on COVID-19, and rightfully so, and on COVID-19 vaccines. So people are talking about the COVID-19 vaccines, and they will be talking about giving COVID-19 vaccines to their child. So this would be, if they are reaching for COVID-19 vaccines for their child, it would be a prime moment to ensure that the child is up to date in all of their vaccines, and if they're not, to provide any vaccine that would be needed to catch up on that. So certainly there's been interest from public health units here in Ontario to do such a strategy that will make their catch-up strategies much easier. So the folks that we've been working with at the public health level have been very enthusiastic to see this recommendation change, and would make things much easier indeed. Certainly, you know, when the vaccine will be rolled out in 5 to 11 years old, it will be important to consider potential catch-up strategies at the same time as the vaccines are being rolled out. And thank you for highlighting that.
Yeah, that's great. I am really curious to see what's going to happen in like the next couple of, you know, the next 6 months from now or so, and to see how maybe vaccination uptake might increase, so hopefully post-pandemic wise. So it would definitely be interesting to see what will be happening. So I'm just waiting for some more questions to come in, but I noticed you mentioned this as well in the presentation, but did you find any other similarities with other research that was being conducted across different provinces? I know you mentioned Alberta with the vaccination uptake of specifically that 15 to 18 month lag when it was when we were during like the pandemic and during lockdowns with a lack of vaccine uptake.
Yeah, so I mean, unfortunately, there's scarce data that we've seen from other provinces, and her focus was mostly in Ontario. I know that Dr. McDonald has worked on this question quite extensively in Alberta, and I believe that she has reported similar trends as well, which is not surprising. But what she's our focus was mostly in patients aged 0 to 2 years old, whereas she looked at all ages across the board. And what they've been reporting is that the impact was more significant in older children, that is 4 to 6 years old, and in school-aged children. So we still need to do this work. And unfortunately, it's a bit more challenging here in Ontario because of some of the caveats that I've mentioned with respect to the assessment of immunization coverage. That is that vaccines that are given in public health units and through school-based immunization programs will not be captured by EMR data, because they will not be given by primary care providers unless they would be given in primary care settings, because this has been one of the strategies adopted by public health to ask primary care physicians to help with the catch-up immunization programs because schools were closed. But we may not have very good data to assess this question specifically compared to what can be done in Alberta with their central registry that includes both routine childhood immunization and school-based and immunizations that are given in children who are school age because of their delivery mode by public health.
Yeah, that's definitely a good point of how different each province is in terms of capturing data. And we had Shannon McDonald on for our last webinar. And of course, that webinar recording is also available upon request and will soon be made publicly available. But yeah, those are definitely great points. Oh, it looks like we have another question. So the question is it possible that vaccine hesitancy towards COVID-19 vaccines could have impacted vaccine hesitancy towards childhood vaccines? Is this something that will be assessed at some level, like a qualitative data perhaps?
Thank you very much for such an interesting question. Yes. And it's a question that I'm really interested in. There is some data out there. There is some qualitative studies that have been published mostly from the United Kingdoms on that topic. I do believe that Dr. McDonald is also looking at that question in Alberta, but certainly it would be important work to conduct here in Ontario. Because as you could see, I mentioned her work with respect to a survey study that was sent to practitioners and the study that we've done in looking at epidemiological trends. But what we have yet to do is to talk to caregivers. And there could be various methodologies to do that, including some qualitative methodologies that would be of interest to ask them their perspective on routine childhood immunization and how this has changed towards the pandemic. There is a thought that COVID-19 has made the potential threats of an emergent infection that can be prevented by a vaccine very real, compared to some of the other diseases that are prevented by vaccines. Like, for example, like the possible threat of polio or the possible threat of diphtheria is very remote in people's mind. Whereas for COVID-19, it's very real and it's very concrete. People may tend to know somebody who was diagnosed with COVID-19 or may have unfortunately passed away from COVID-19. And I've been seeing the numbers of COVID-19 in the province and may have, seen and acknowledged from a very concrete perspective that COVID-19 vaccination have allowed us was one of the strategies that was very important, to protect ourselves against the virus. So it can go either this way, or it could go either the other way. There's a lot of media attention around vaccine hesitancy with COVID-19 vaccines, and let's say that some of the communities that are vaccine hesitant have a bigger platform than before, or maybe more vocal, but it remains a very tiny subset of the population. But it is possible that there may be some spillover from that hesitancy towards other vaccines. And indeed, time will tell, and we will need these other studies to really assess what is happening.
Great. So we have one more question that I think we have time for the rest of the remainder of our time for the webinar. Our question is, how much testing has been done on the vaccine for children? So I'm assuming it's the COVID-19 vaccine, to ensure it is safe as possible. I know some parents that are fearful of that.
Yes, maybe I could. Are we talking about the COVID-19 vaccines for 12 to 17 years old and children in general, or 5 to 11 years old?
It's not specified in this question.
COVID-19 vaccines in general. Yeah. So I mean, that's why I'm asking this question, because each age group is quite different. So
5 and older. Sorry.
5 and older. Sorry.
Thank you, Carol.
Thank you very much
for COVID. Thank you.
That's right. So for 12 to 17 years old, I mean, the vaccine has been rolled out since many months now, and we have a lot of data on its safety and its effectiveness. For 5 to 11 years old, the data from one of the pharmaceutical companies, so from the Pfizer-BioNTech Comirnaty vaccine, the data just came out last week. The data that was sent to the FDA in the United States. The FDA is meeting today to discuss this data and to see if the clinical trial that the pharmaceutical company has led has shown what is needed to be shown with respect to safety and with respect to effectiveness in the specific 5 to 11 years old population. And if and only if it meets the FDA criteria for safety and for effectiveness, then they will approve the vaccine in this age group specifically. And a similar process will be undertaken here in Canada, that is to undergo Health Canada review to make sure that the vaccine is safe and that the clinical trial was able to show that it is safe in this specific age group as well as effective. And once they will do that, the National Advisory Committee on Immunization will review this data. So there are still some processes to take a very close look at this data because especially for 5 to 11 years old, there is a lot of scrutiny to make sure that before these vaccines are being rolled out, we are extremely confident that they are safe and that they are effective before they can be used clinically.
Right. Awesome. Well, thank you so much for those for sharing your questions, and thank you so much again, Pierre-Philippe, for yet another wonderful presentation. I guess that brings us to the end of our webinar for today. Thank you all for joining us. You'll receive a post-webinar email from me after the webinar, just to give you an update on our upcoming webinars, as well as how to access the webinar that was temporarily available upon request. Also, don't forget to fill out the survey. And thank you, everybody, and have a wonderful afternoon. And thanks, Pierre-Philippe.
Thank you very much, Antonella. Thank you for the opportunity.